Y'all use ketamine, right? You use ketamine for all the things. You use it for agitation, you use it for pain relief, use it to facilitate intubation. Maybe you even use it for seizures. Hell, I don't know. Maybe you're treating depression out there, but you use ketamine. You're probably using a lot of it. The big question is it safe to use ketamine? And I'm sure you have your opinions. I, God knows, have my opinions. But there is a new paper out that is suggesting, maybe it's suggesting that ketamine is associated with more adverse events than perhaps we recognize. I want to talk about this paper. And one of the things that I want to talk about is how a paper might be construed by the general media or, let's say, lawmakers, and how they might misunderstand science. Now, I know for our American listeners, there is no way you would ever believe that lawmakers and the public might misuse science and might not know how to read it. But just if you humor me, we're going to talk about the potential. And to do that, we're going to bring in our friend Dr. Remle Crowe. She has done some work with ketamine and she has some great opinions. We're going to run through this paper, and then we're going to talk about some of the dangers, some of the challenges of how other non-scientists interpret scientific literature. Stick around, we'll be right back.
What is a lighthouse? It is a tower with a bright light at the top, located in an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of clinical practice. The paper I have for y'all today is out of the Toronto, Canada area, 3 paramedic services, and what they're telling us is about their experience using ketamine. And the title of this paper is Paramedic Use of Ketamine for Severe Agitation and Violence. This was published in the Canadian Journal of Emergency Medicine. It is hot off the presses, so hot off the presses that I don't even have a full citation for you. And so hot off the presses, I actually had to get the paper through Interlibrary loan. So Dr. Kwong is the lead author, and you may notice some other authors here, including Dr. Verbeek and Dr. Cheskes, Dr. Cheskes of the DOST VF trial. So the paper that we're going to talk about here is really a descriptive study of their experience when they launched this new protocol. So let me tell you how they set this question up. And I think they did a pretty good job in the introduction. So the introduction of a paper really is where you set the hook for why what we're going to tell you might be important. And a couple of things here. They say, you know what, we've been using ketamine in the emergency department effectively and safely for years and years and years, for agitation, for analgesia, for all the things, very safe. It started off in the field in the early 1990s, but for some reason, we have not demonstrated, and by demonstrated, I mean published, similar safety in the pre-hospital environment. And that is despite EMS clinicians having the same ability to safely administer and monitor patients. The literature just isn't there. And as a matter of fact, there is some literature that suggests maybe patients that we give ketamine to get intubated more often than perhaps they would if we didn't give them ketamine. Now, I can hear you right now saying the things that I both feel and say, which is just because you intubated them in the ER doesn't mean you needed to intubate them. And maybe just because you didn't listen to me say that they're unconscious because I gave them ketamine and intubated them, Who knows? Maybe there are reasons, but there is some evidence for that. They also reference, I believe, the first 3 references are papers Dr. Crowe was involved with, including one that Dr. Fernandez and Crowe did with the ESO dataset that describes 8.5% of patients who got ketamine had some hypoxia and 17% had hypercapnia. If y'all will remember back on one of our prior episodes, we had Remle on to discuss this, and we really said the main takeaway is if you're going to give ketamine, please monitor them appropriately. So that's what they did. The key methods here, they just pulled all charts where ketamine was given, and they had 2 EMS physicians that went through, looked at all of them, identified what the indication was, and then identified whether there was an adverse event, and if there was, how likely that adverse event was to be caused by ketamine. Now, that's the thing I want to talk a little bit about. First off, something about the protocol there in Ontario. Ketamine is allowed to be used on standing order for agitation, but if you want to give it for analgesia or other reasons, you need to silence your phone first. Sorry about that. You need to call online medical control. So you can use it for analgesia, procedural sedation, CPR-induced consciousness, all the things. But that's online medical control. Standing order is only agitation. So I mentioned the 2 EMS physicians reviewed it. They identified the indication, and there were basically one of 3 things. What they called endogenous causes, which is the agitation. They're drunk, they're psychotic, whatever the issue is. Then there was analgesia and procedural sedation. They have a list of definitions of adverse events, and they would identify whether one of those adverse events occurred, and then they judged each adverse event on a Likert scale from 1 to 5, where 1 was very unlikely to have been caused by ketamine, 2 somewhat likely, 3 equally likely and unlikely, 4 somewhat likely, 5 very likely. And we're going to come back to this in just a second. So that's really what they did. Let's talk about what they found. So you can see from this table, this is just a description. Most of the patients were given ketamine for agitation. Most of these patients got ketamine as their first drug, over 80%. And then over 80%, this was the only drug. They also had the option of using midazolam, but for these patients, ketamine was the first drug, and ketamine was the only drug very frequently. All right, what was the dosing? If you look at this slide, if you happen to be watching the YouTube video, this is a slide of dosing. They have it broken down by IM and IV or IO for endogenous reasons. And basically, what you're seeing is pretty normal dosing. If you're giving it IM for agitation, it's around 4 milligrams per kilogram. If you're giving it for pain, it's less than that. If you're giving, it's like point something IV. And if you're giving it for procedural sedation, it's around 1 milligram. So for agitation, IM around 4 milligrams. IV is less than that, somewhere around 1 to 2. What did they identify as the adverse events? Well, hypoxia, airway compromise, secretions or emesis, hypotension, or cardiac arrest after ketamine. And we definitely want to come back to that one. So they have a table in here that says, okay, so they had an event. What did you need to do about it? So if there was an adverse event and we didn't need to do anything about it, probably wasn't that adverse of an adverse event. In 20%, they had to give some supplemental oxygen. 12%, they had to use an airway adjunct. 6%, they had to do mask ventilation. And 2%, they had to do a supraglottic. Now, they also tried to say for the adverse event, for example, hypoxia in 15% of patients, how likely was it that that adverse event was caused by the ketamine? Remember that Likert scale? They dichotomized it, broke it into it was likely or not if you got a 3 or better. So if you said it was equally likely or unlikely, that was included in here as caused by ketamine. I have a problem with that. Often when you look at papers, you have no clue from, or when you look at papers, when you look at charts, you just can't tell if the ketamine caused it or not. They have can't tell here listed as caused it. All right. So these are the results that they found. What was their capsule summary? So I think the capsule summary in general was reasonable. They said, what do we know? We've used it an awful lot. It's pretty safe in the ER. What does the study ask? Well, how safe is it in the field? And what they found was 30% of patients had adverse events. And their takeaway, why does this study matter? They said, and I just want to read this if you're listening only, pre-hospital ketamine use will likely increase over time, and paramedics should be prepared for the frequent occurrence of adverse events. Frequent occurrence. Frequent occurrence seems ominous. Remle, welcome, and I want to get your take on frequent occurrence. Glad you could join us.
Yeah, thanks for having me, and thanks for this mug.
Absolutely, yes. That's a nice story there, buddy. Your data is noted. Can you bring
Yeah.
the real stuff?
So good news, we've brought a lot of data to this one.
I like it. I like it. So,
And
Remle, you just listened to me, as our poor listeners did, blather on and on and on about this paper from our friends in Toronto. Let me get your first take on this. What did you first take? Um, you, like me, probably didn't get to read it as soon as it came out. You probably only had access to the abstract. I know you and me, and I think Jose Cabanas sent it to both of us in a text thread. All we could see was the abstract just because it was so fresh. What was your take when you read the abstract?
right, so my first take was, wow, there's some strong language, especially in the conclusion. Let's get the full paper and find out more about these methods because a lot of this goes against what some prior work has found in terms of the frequency of adverse events. And then, of course, in the context here in the United States with the House Bill 1251 in Colorado and some other legislative events around ketamine, I think it's really important that we are particular with our words. And so my first thing was I need to see what the methods were because 1 out of 3 patients developing an adverse event after ketamine is something to all be concerned about. And so that's exactly what we did.
So, Rimley, you mentioned the House Bill 20 something. I can't
1251.
keep. Yeah, tell me a little about, remind us, and I know we've had an entire episode about this, but why don't you tell us as a reminder what that was and
Yeah, and
why it
anytime
was?
Absolutely. And anytime we talk about this, I think it is important to still keep in mind that there's humans behind the numbers and that we are not saying that that person's life was not important or anything like that. What we're trying to figure out is what happened in these cases that got highlighted in the media. Are those what we would call a sentinel event, or is that common practice? And we should be concerned and we should be doing something. In this case with Colorado House Bill 1251, I had the distinct, I'm going to say, privilege, honor of being called in to testify and get 3 minutes in front of everyone and tell them what you know. And what this bill was initially worded to do was basically take ketamine out of pre-hospital practice in the space. And
Completely.
completely, this was
Any reason.
initially a ban ketamine bill. How and the language in the bill then got softened a little bit, but still had some concerning points to it that could create unintended consequences, like EMS not being able to be influenced by peace officers. And you could see how that could potentially influence our on-scene communication strategy because what is influence? If I tell them what I saw, is that influencing the clinician's decision, et cetera? So,
Right.
and then there was also my favorite part was that you need to weigh the patient before you administer the medication.
Right.
Please step onto the scale. We
And
we
the
laugh.
don't use ketamine to take them to jail because clearly that's happening all the time.
Clearly, that's happening all the time. So what we did with that is we went to the literature, and that's that Dr. Fernandez's paper there is, let's see what we know from a very large data set across very diverse practice settings and see if what we have is truly sentinel events or if that's common practice. And by and large, we found that ketamine use appears safe. Like all medications, there certainly are things that we should keep in mind. But by and large, there were not these treat and release things happening or everybody getting 10 times the normal dose or you name it, whatever was in the media at that time, we took to the data set and did a little bit of myth busting with data. What that resulted in is because we had a seat at the table during that hearing, the language was officially modified in that bill. Now, the bill still has, restricted some things around the use of ketamine in that state, but without the data, that bill would have been worded very differently.
I think it's important. First off, I want to thank you again for testifying in that bill. I think it's always important when we make decisions that we make them based on what's actually happening instead of what we think is happening. So I very much appreciate that. I think it's important to remember the context for that. It was around the Elijah McClain case, a horrible, horrible case that I think everybody agrees should never have happened and didn't have to happen. The key issue, though, was some assumptions that were made, and the assumptions were that ketamine is killing people. And it wasn't so much that they didn't look at the perhaps inappropriate positioning or um, l- inhibiting the ability to breathe or sedating patients that didn't need to be sedated at all. It didn't look at that. It just said drug bad. So, I mean, this is how we end up saying ketamine, bad, ivermectin, good, regardless of the case. Just use it. So,
Yeah.
I appreciate that. This is perhaps the reason I don't know that I don't know that Jose would have sent this to us. The reason we are so focused on this paper is because of our concern based on your experience in Colorado and concerns and conversations that have come up, trying to remove what is, I think, a very useful drug from practice for reasons that aren't founded in science. So maybe we're just a little bit sensitive about the topic when it comes to this.
Yeah, and it's not a jab at the paper, but the last sentence of that abstract is what really struck me. It says paramedics should be prepared for the frequent number of adverse events after ketamine use, full stop. That sentence could easily be taken out of context. And I know that the authors understand the nuance beyond that sentence. And we all, as
Right.
clinicians, understand baseline, these patients were very ill and they had a high likelihood of an adverse outcome with or without treatment. Hopefully, the treatment reduces the likelihood of such an adverse outcome for them. But just that sentence alone and that it's able to be accessed without going behind the journal paywall, that is something that for me was okay, well, let's dig in and be ready to talk about this paper because surely it will be brought into other conversations and we need to be ready to talk about those nuances.
Yeah. Yeah. I I really am thinking about context here. And as I read the paper, I'm like, well, this is actually a reasonable paper. I think their one method I have a problem with, and I'm sure we'll get to talk more about that. But overall, I think this is a reasonable paper. If I were going to do something like this, I think I'd probably do the same thing with one big exception. I think we are just very sensitive about it. So, hence the conversation. So, let's dig in a little bit. I've already hinted about my problem. Why don't we get your thoughts on the methods? You are, after all, a professional methodologist and a very good one.
I do love the methods. In this case, I think their methods are generally okay. It's a nice, descriptive, thorough evaluation of a full cohort of patients in a given geographic region that has not been previously described. So, as a reviewer, I like what they did there. I know which method that you're hinting at, and we can certainly talk about that. The key component here for me is not so much a jab on the methods as it is how we need to place this in context. So there is no control, there's no comparator group. And that is important missing context because when we see an adverse event rate of 30%, is that good or bad? What were my alternatives? What would the alternative be to treat this patient or not treat this patient? And that's where we don't have the information in this paper.
I think that is such a key thing here. You can look at this and said, oh my God, 30% of ketamine patients had an adverse event, 1.9% required an invasive airway. Ketamine must be bad. Well, we're not comparing this to anything. And my main takeaway is that if there is a patient who is so agitated that you have to give them ketamine, these paramedics had an option of giving midazolam. They chose to give ketamine. There's an indication here. And I think the indication tells us this is a sick population of patients. And that's what I hope people will take away is if the patient is so agitated that you have to sedate them with ketamine, that is a sick cohort of patients, and we need to pay attention to them. I don't think there is anyone out there who would see a patient who is pale, diaphoretic, hypotensive with massive ST segment elevations and go, you know what? Nothing bad's going to happen here. Why don't you just walk to the stretcher? Well, no, people are going to recognize that's a sick person. I hope that people will recognize if they are so agitated, you have to sedate with ketamine. They're sick as hell, and we should be monitoring our sick as hell patients.
I think that is really the key takeaway is it we need to avoid language like ketamine is dangerous, but at the same time, we need to account for that any medication comes with consequences. And so where the real importance is emphasizing things like airway monitoring, end tidal CO2, post sedation being one of the big ones that we've looked at before. Agitation bundles, obviously, including de-escalation as a first line. Obviously, in this cohort of patients, that is not going to be effective for a number of reasons. And then having medical oversight versus these knee-jerk reactions to categorical bans, right? That's where we need to focus on. The other consequence of having a ban on a medication like this is we could potentially prolong, a struggle or hypoxia related to that underlying condition.
I think here's the issue that I think those of us in the field recognize. When you have an agitated patient, they are a danger to themselves, they're a danger to others, they are acutely sick. Just ignoring them is not an option. We have to do something. So what is that something? So we can give them ketamine. It's rapidly acting, it's effective, it will sedate them. And then they're in a position where we can adequately assess and manage them. But if we don't use ketamine, if we just leave them alone and just restrain them, well, the reason these patients die is because of the restraint. And they are metabolically active. They have to be able to blow off their carbon dioxide. Otherwise, they're going to get profoundly acidotic. And when we restrain them, if you are never going to sedate them, you are highly likely to end up restricting their minute volume and their tidal volume. So that's a problem. Doing nothing bad. As a matter of fact, doing nothing is likely, almost certainly worse than using ketamine. Is there another agent out there? I don't know. I mean, suggest one to me. I don't know of one that works as fast as ketamine. So, and y'all know I'm a huge fan of droperidol, but droperidol doesn't work as fast. Remle, you mentioned hypercapnia. Your paper with Tony talked about, I believe, a 17%. Um, how many people didn't have end-tidal CO2 at all?
It was
Do you
about
remember
1
that?
out of 3.
1 out of 3. So you have an analogy that I use all the time, and I want to give you credit for it, and I want to hear your analogy. Remind us your analogy about trying to determine a patient's respiratory status looking only at SpO2.
So I don't think I came up with this one. I've definitely heard it somewhere in that if you're, waiting around for SpO2, there's a lag. And so that's like driving down the street looking in the rearview mirror versus if I'm looking at entitled, that's a more real-time look at what's actually going on. And so that's staring through the windshield.
I love that analogy. I don't care who said it, you get credit for it.
No,
So
I'll
I've
take
been
it.
crediting you for it. So, Remle, we have talked about some work you did with Tony, and that was describing all uses. You've done some other work on this, haven't you?
I have. So, me and Dr. Lawrence Brown, who literally wrote the book on EMS research that's right behind me,
He
uh,
did.
while this the heightened political environment around ketamine was going on, we decided to take a look at some of the alternatives. So if ketamine were to go away, what would we have left in the toolkit? And can we compare how adverse events line up in those cohorts? So we looked at ketamine, benzodiazepines, and antipsychotic medications as the three classes. I know that your heart is broken. Droperidol was not in there. At the time we did this study, droperidol was not back yet.
Ah, the dreaded back order.
There's a study for you to do.
I
Uh,
know.
so really this, and again, definitions are really important here, and I didn't talk about this, but in the paper, there's an appendix with their definitions for what the adverse events are, and I think it's worth actually looking at that appendix if you are gonna read the full paper. This paper, they do a great job at telling us what those definitions were if you go to the appendix and look. My fear is that not everybody's gonna go to the appendix and look at, well, what was their definition on hypoxia? And so they have a consideration for whether or not there were pre sedation vital signs, which we know that in some of the sickest of the sick patients, getting a blood pressure, even getting a pulse ox is not always possible. And so there's something different about that group of patients, the one third of patients where we couldn't get pre vital signs likely. And they do include patients with their first reading after sedation, if they had no readings, of a less than 90%. The problem with that, or the consideration to have with that, is whether or not those patients were likely hypoxemic prior to the sedation. And if we're able to correct that with bag valve mask ventilation, oxygen, that is an anticipated side effect that we should be ready for.
Fair
So
point.
back to our comparative paper, we want to know, okay, a lot of these actually reported statistics in the Canadian paper match very closely to what Lawrence and I found looking at the ESO Data Collaborative. So this is 8,000 patients from 1,000 different EMS agencies. And in the paper, we do propensity matching and a lot of things to compare the rates here. So again, just taking the list of adverse events, we define serious adverse event as cardiac arrest, an invasive airway, or what we defined as new onset severe oxygen desaturation of less than 75%. So here we can see that the overall rate of these adverse events is extraordinarily low. We do see higher rate of oxygen desaturation with ketamine. So that's 2.6% versus 1.3% with a benzo and less than 1% for an antipsychotic. So that's something to pay attention to. But residual confounding remains a possibility. The choice of ketamine is not random. We grab ketamine for the sickest of the sick patients. And so even in this context, we should still interpret carefully. And then looking at the any adverse events, which we defined a more broader set, meaning the patient had positive pressure ventilation or any oxygen reading was below 90%. They had an oral or a nasal airway, suctioning to get at the concept of hypersalivation or emesis. Looking at this again, now any adverse event in the full sample was about 1 out of 10. So that does say, as EMS clinicians managing this very sick cohort of patients, we should be ready to manage their airway and prepare for any of these things. But that's 1 out of 10. With ketamine, it was higher at 18%, largely driven again by the oxygen desaturation. But we're looking at an 8.7% or a 5.4% among benzodiazepines and antipsychotics. So this just gives us some descriptive context. Again, it's not causal, and we can't say that ketamine is worse or better because, again, there's likely residual confounding. These are patients who are likely much sicker than the other cohorts. But this does give us some context around what do adverse events look like in my other options if I were not able to give ketamine as an example. And you'll see a lot of these line up really well with the Canadian paper that we're talking about.
Really good points. So, you were talking about methodology. Let's, if you don't mind, since you clearly know what irked me so much,
Mhm.
why don't you, and I have been irked by a lot of papers. This was a minor irk, but so I don't want to get too
Low on the
uptight
ERK
about it.
scale.
Right, exactly. We need a Likert scale on Jeff Irksome. Um, do you want to talk about when you dichotomize a continuous variable, the importance of where you pick?
Yeah, so on any Likert type scale, we're looking at, it can be anything from a 1 to 4, 1 to 5. In this case, they do have that neutral category of a 3, meaning equally likely or unlikely that ketamine was directly related to this consequence. And so in this case, Jeff already mentioned the irk is that the 3, the we're not sure, got lumped in as did cause. And the more irksome for me is that we don't to see the breakdown. I would have loved a table that shows me how many were 3s. My hypothesis is that a lot fell into that 3 category, but I could be wrong, and my interpretation might be different if I could see, "Oh, these are all 4s and 5s. Ah, there's definitely something going on there." But that 3 just sort of blurred everything for me.
It does seem like a pretty obvious table would be a frequency table of how often did you see, just what proportion of these were ranked as a 1, as a 2, as a 3. So if what you see is very few of them were 1s, 2s, most were 3s, very few were 4s and 5s, that really skews the data, and I think it makes it very difficult to make conclusions. If I saw that, my conclusion might be, we don't know. On the other hand, if it was very flat and skewed toward the end, that would say, okay, then maybe these were more likely to be caused by ketamine.
This is still a really important finding, and I don't wanna take away from the number regardless of what caused it from a practical and tactical standpoint. As a field EMS clinician, I should still know that if I'm considering giving this medication, I should be ready to manage some of these potential consequences or potential things that might happen with or without the medication. And so the causal attribution for me as a field clinician may not be as important as the I've gotta have my training, I've gotta have my monitoring ready to go, and be ready to get this patient safely to the receiving facility.
I think that's not only a good point, but it highlights the whole reason we're having this conversation is because of the attribution, right? I think if this paper had just said 30% of patients have some adverse event who get ketamine, not after they get ketamine, just watch out for it. I don't think we'd be having this conversation. It's the attribution and the implication that others might take away from it that it's challenging. When we talk about, I wanted to give a couple of examples because the paper reports some cardiac arrest, 3 cardiac arrests that occurred after ketamine, and then they tell us what their score was. And I think this gives us an idea of maybe what the distribution may have been. It's hard to compare cardiac arrest to non-cardiac arrest, but I'm gonna do it anyway. So let me just read the cases. Case 1, 60-ish male who had an SVT and VTAC. Now, first off, I'm not sure there are a whole lot of people that have SVT and VTAC. I think there are a fair amount of people who have a fast, wide, complex tachycardia that we can't differentiate. So I'll just take that. It's going fast. It seems to be wide. It has a pulse. The patient progressively became hypotensive and hypoxic. Then ketamine, 100 milligrams, was given for procedural sedation before we went ZAP. We went ZAP 3 times, did not convert the rhythm. The patient went into cardiac arrest. Where would you put that? I would put that as beats the hell out of me. I don't know whether ketamine, I mean, it sounds like a pretty sick dude. He was already progressively hypotensive, and tachycardic or hypotensive and hypoxic, really suggesting to me that maybe this was VTAC. Who knows? I would probably call this a 3.
Yeah,
I just
and
don't know.
so we had this struggle too. In the paper that Dr. Fernandez led, we reviewed every single pre-hospital and in-hospital death. And the
Y'all used
3
a slightly different definition though when you were trying to do attribution. Talk to us about
We
that.
did. Yeah, so but it was hard. So the definition that we used was, could ketamine be reliably excluded as a contributing variable? So in this case that you just presented, could we reliably say that ketamine was not involved? I think we would probably say no. So this patient
Right.
would have fallen into the maybe bucket, but we did keep that as a we didn't say ketamine caused it. We said we could not reliably exclude ketamine as a
Right.
contributing cause.
And y'all started off with, if I remember correctly, there was no continuous variable Likert at all. You just started off with a continuous variable, and it was a very, very conservative
Yeah,
definition,
and we
if
published
I'm
all the cases the same way that the authors did here
yeah.
for that transparency of let folks make their determination based on their clinical experience, but these cases are very challenging and we're likely not going to get to causality in many of them.
Let's hit case two again, 60s. Polysubstance abuse presented with violent behavior. Rock on Canada. This is my patient population here. Patient was sedated with 350 milligrams of intramuscular ketamine, subsequently developed respiratory depression, had assisted ventilations with bag valve mask, then developed bradycardia and subsequent PEA, ranked greater than or above 3. I don't know whether it was 3 or 4 or 5. I would be tempted, probably put a 3, but may lean more towards a 4. This bradycardia and PEA arrest strongly suggest hypoxia. I suspect this was a hypoxic bradycardic cardiac arrest. Knowing what I know, one of my pet peeves is none of us are mask ventilating well. Um, who knows what the restraint was, but ketamine can cause respiratory depression. Sure, I think that's a reasonable one here. Case three, they rated this less than 3. And let me give you an example of what they would do there. This is a 40-year-old female, 40-ish, intubated after cardiac arrest. She got ROSC, then she had persistent hypoxia and hypotension. So she has a pulse back, but it ain't a great pulse. She got 20 milligrams of IV ketamine twice for sedation because of patient ventilator dysynchrony. Ketamine was given 5 minutes after and then 15 minutes after ROSC, but the patient rearrested 10 minutes after the second dose of ROSC. Typical half-life, the duration of effect is somewhere between 10 and 15 minutes. I would have a hard time blaming this one on ketamine, and so did they. They ranked this as under 3.
Right, and
So
there's some good work by Tanner Smita showing the rearrest rate, and this is
oh, yeah,
consistent with that
40%.
work. Mhm.
Yeah, Tana did bastard. Um,
Would it be a podcast if we didn't talk about the almost Dr.
exactly,
Smita?
right? All right, so those are the key things that I wanted to talk about with this paper. Um, the My takeaway here is this is a sick population of patients. This paper clearly identifies it's a sick population of patients, and ketamine is not perfect. When you do anything to sick patients, even just walk past them, bad things can happen. And ketamine is no different. There are adverse events. This is the same point you were just making. I think we should probably just really emphasize it. If you're going to give ketamine, for the love of God, assess them, get off their chest, and, unless you're doing CPR. Don't restrain them, get off their chest, and make sure that you're adequately monitoring ventilations. And there's only one way to do that, and that's with waveform and tidal CO2. Do you have any other final thoughts for us?
Yeah, for me, it's don't jump to a knee-jerk conclusion from an abstract of a paper. Make sure that we understand the definitions and the context around something. So going to the appendix in this one is also really important. And I'll be talking about a lot of these pitfalls actually very soon at EMS World, bringing in some cute dogs as well. Plug for that.
Tell me all about that. You and Ollie are doing that, right?
Yeah, me and Allie are going to talk about dogs and data. And so, is ketamine the misunderstood pit bull? We'll talk about it.
I love it.
But I do think that that's a key thing here is to understand how everything was defined, what's the context, and what would the comparison be. And so, for me, safe sedation isn't about which medication; it's about being trained, prepared, the monitoring being the probably the biggest thing, and so ensuring that the sedation is for the right patient population. With that, we're likely to do a lot better by our patients than worrying about this medication or that medication or which one we're going to throw out today.
Great point. Great point. As always, for our policymakers, read the data. Please be influenced by the data and not, and be, if you're going to be influenced by someone's opinion, for the love of God, maybe assess whether they know what the hell they're talking about. If I were to try to, oh, I don't know, I'm just going to throw this out there. offer an opinion about the constitutionality of something, don't take my freaking opinion. I'm a doctor. What the hell do I know about it? Ask a lawyer. On the other hand, if you want to know something about medicine, you might want to ask a doctor instead of a lawyer. Just going to, toss that out there. All right, guys, as always, thank you for listening. Dr. Crowe, thank you so much for joining again. Always a pleasure talking with you. I can't wait to see your talk in Indianapolis, right? For EMS
That's
World.
right. Coming up
Should be
fast.
fun. Take care, y'all. Have a great day.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.